Senator Lankford is next.
Chairman, thank you. Thank you all for spending your time here. A lot of things you could be doing today. Thanks for being here and be a part of it. We've all talked about the physician fee schedule and the struggle with that. That is frustrating for all of us, but especially for physicians on it. I am one of the folks that thinks we need to incentivize more doctors coming into the process rather than the next generation of folks thinking, I don't want to do that, to be able to deal with the hassle of that all the time. I'd like for more folks to be able to come into the process. We have several things we've kind of highlighted on. I'm not going to go through as well, but the critical access hospital piece has been a challenge in my state, in a state that's split evenly rural and urban, and trying to be able to manage that. We have a bill, Rural Hospital Closure Relief Act, which gives some states some flexibilities. We have not talked about physician-owned hospitals, but that continues to be an issue long-term, with allowing physician-owned hospitals to continue to be able to grow and to be able to take care of their patients. I do want to talk a little bit about this prior authorization. Dr. Furr, you've mentioned this a couple of times as well. We have hospitals in my state that are just no longer taking Medicare Advantage because of the prior authorization issue on that. How does that get resolved? What do you see as a solution to that?
And you're seeing physicians refusing to take them along with that, and it's a huge hassle. It takes a huge amount of time. I think physicians need to be able to practice, and again, it's for big budget items. I don't have a problem with prior authorization, but when it comes to basic drugs and basic things that we need to do, just to give you a perfect example, if I got a patient with acute abdomen, it's easier to send them to the emergency room because they don't have to get a prior authorization to do their CT scan than for me to do it in my office, because it could take me a day or two to get that done. So the prior authorizations, which are meant to control costs, in many ways are actually increasing cost. And sometimes the best drug might be a more expensive drug, but it's better for the patient because it might lower their cardiovascular risk along with taking care of their diabetes or their hypertension. So those are all issues with prior authorization that keep us from providing the best care that we can and actually drive up cost.
Okay, that's helpful to be able to get context. Ms. Matthews talks a lot about the value-based care and some of the issues and the innovations that are there. We have 34 ACOs that are operating in Oklahoma. They've saved Medicare about $50 million, the best we can guess, the last couple of years on it. But I do want to give an example of this. We have one ACO in Oklahoma that saved almost $9 million just in 2022, but they missed the minimum savings rate by 0.17%. So here's the challenge. What recommendations would you make on making changes to the shared savings plan to make sure that we've got more ACOs and that we don't actually frustrate entities that are trying to get into this?
I think building in the stability for the long-term commitment to the AAPM and engaging with CMS and Congress on the importance of accuracy around benchmarking. We had through COVID very different utilization patterns, and those were realized very differently depending on the state that you lived in as well. And so when we look at creating national and regional benchmarks, there is some implication from the time in the benchmarks from COVID, just because of the utilization and historical expenditures. So that certainly created some of those methodologies. The other thing is we're learning. We're learning so much. And so I think I applaud the work that we're doing to take a look at what we called the lessons learned in the models and how do we continue to iterate on those to be more successful for the models in the future.
Okay. I want to ask about something we've not talked a lot about today, and that is hospice care and how it interacts with Medicare, just for the care of patients and individuals. I know that's set up typically for the last 6 months of life. Not always. We have a rather famous example of that in President Carter that I think has been in hospice care 14 months, I think at this point, or approaching that. The design of it is to be able to help with end of life, to be able to help through families, to increase some benefits in some areas and decrease them in others. I walked through this recently. I won't go through all the story on this, but with my own mom, who was a Parkinson's patient for years, who passed away a year and a half ago. But some physicians, towards the end, were talking to me about hospice care, and we're walking through that as a son and a mom and a physician. And I was advised, well, you know what, if hospice care is not working out and you want to come see a specialist or whatever it may be, you can just drop it, go back into Medicare, be in Medicare for a while, then drop that, go back into hospice care. And I suddenly understood there's a loophole in the system that's literally being built in and that's being exploited. personally watched firsthand in that. Other issues that are like that, what would you recommend on changes on hospice care and ways that we can help families in those moments, whether that be in the value of it or what needs to be done to be able to improve hospice? I'm open to anyone who wants to contribute.
I'm happy to contribute. Thank you so much for the question. So I think a couple of things to highlight here. I think first, one thing that's actually quite interesting is another federal program, the Veterans Health Administration, provides a benefit to veterans where when they opt into hospice, they actually don't have to forego regular care, life-extending care. And I believe the latest estimates from the VA is that is a cost-saving program for them still, because it allows palliative care clinicians to come and educate patients and align care with their preferences without what might seem to a family or a patient a somewhat draconian thing, which is I've got to walk away from opportunity to other care. So that's one thing to contemplate. The other thing is our hospice payment system also has opportunities for improvement. There are some peculiar incentives in that we have caps on how much hospice, sort of duration of care that hospices can give. Those create distortions. So it's unclear that those caps are actually doing well for our beneficiaries, and that's something else that could be contemplated.
Time, my colleagues expired. Senator Warren.
Thank you, Mr. Chairman.